My presentation is about pediatric burns. My name is Kim Goyana. Health professionals have been treating children with burns for millennia. However, pediatrics as a separate specialty only came about in the early part of the 20th century, when burn units only started to appear at the time of the Second World War. Medical advances over the past 3 decades have resulted in declining mortality and shorter periods of hospitalization for children with burns when treated in a specialist burns unit. Epi- Epidemiology of burns in children. It is estimated that over half a million children are hospitalized with burns injuries per year in the world, with the majority occurring in the low-middle income countries in Asia and Africa. Low socio-economic status of the family and low educational level of the mother are the main demographic factors associated with the high risk of burn injury. The overall care of a child with burns is dependent on the depth and extent in the injury. Thus, a multidisciplinary service approach is introduced. This is a theme to ensure that every aspect of children's physical, psychological, social needs is met during hospitalization and following discharge. For initial presentation, the multidisciplinary team including doctors, nurses, acute pain service, dietitian, occupational and physical therapists, social workers, mental health staff, psychiatrists, music therapists, uh, play diversional therapists, and teachers. Assessment of burn severity. In the hospital setting, the initial assessment of burn severity is history taking and clinical examination. The such information from the child and their parents can give valuable information as the nature of severity of the burn. Uh, Following clinical examination, the child with burns may require intubation, oxygen, or fluid resuscitation. Intubation. Young children have relatively narrow airway and short neck with soft tissues that are readily distorted by edema. Hot gases can cause burn to the airway above the vocal cords and may swell over time to be worse between 12 and 36 hours, thus compromising the airway. Oxygen should be given to all cases of moderate to severe burns in children. Blast injuries can also cause penetrating chest trauma while resulting pneumothorax. Smoke inhalation can cause acute respiratory distress, thus need some medication or immediate um, medical treatment. Systemic toxicity follows absorption of the products of combustion producing systemic acid-base disturbances. Thus needs some problem with the breathing, changes in the voice, or cry, and burns or soot in the nose. Thus this needs to be evaluated. Fluid resuscitation. Burns in small children greater than 10% TBSA, total body surface area, and older children greater than 15% should be treated with intravenous resuscitation. Classification of burn injury. There are four classifications of burns. One is superficial, which means it only involves the epidermis. Number two is the superficial partial thickness burns, involves only papillary dermis and the epidermis. Burns of this depth are expected to heal 1 to 2 weeks and should not result in visible changes to skin beyond 6 months. The deep dermal partial thickness burns. Uh, this involves the epidermis, the dermis. It's usually expected that burns this depth will take longer than 3 weeks to heal. Skin grafting is recommended to promote early wound closure and reduce the degree of residual scarring. Full thickness burns, evident involvement in the whole thickness of the skin and possibly subcutaneous tissue. Skin grafting is essential since there is a little potential for spontaneous healing. Um, essential if a burn, Essentially, if a burn heals spontaneously without the need for skin grafting, with complete skin coverage of the affected area within 2 weeks. Burn wound assessment. A visual examination by an experienced burn surgeon remains the most widely used method of classification. However, many burn centers are equipped with laser Doppler scanner that can determine the depth of the injury up to 5 days of the burn. This is one example of the images that can see how deep the burn is. Pain management. A skilled pediatric pain service is invaluable to any burn center. The service should provide a 24-hour on-call service. Pain-controlled analgesia pumps are utilized with background infusion of morphine for children with developmentally capable. Um, as the patient progresses and pain is well controlled, oral medications such as low-release morphine are instituted. The ideal wound dressing has the following attributes: broad-spectrum antimicrobial activity requiring infrequent changing with minimal discomfort. Other centers attempt to decrease this increased infection rate by taking children to theater for surgical debridement to remove debris and burn eschar prior to application of the non-antimicrobial dressing under aseptic conditions. Pediatric burns rehabilitation. Acute care. Acute care is dependent on the depth and extent of the injury, the age of the child, the presence of infection, the degree of wound healing, and the psychosocial status of the child and family. Management may involve the relief of respiratory distress, prevention of shock, and ensuring all tissues are receiving adequate blood flow. Acute care of children with burns that do not require surgical intervention involves minimizing the risk of infection, assisting wound healing, preserving physical function, minimizing cosmetic deformity, and minimizing psychosocial sequelae by providing appropriate pain relief and ongoing supportive education for the child and the family. While rehabilitation efforts commence from the outset of burn care in order to achieve optimal patient functioning, it becomes more time-consuming for burns therapists once skin closure has occurred. The importance of early and active focus on long-term rehabilitation goals cannot be overly emphasized. Rehabilitation is focused on the prevention of post-acute, such as management of scarring and contractures. It is complications post-burn injury. Contractures. This is inability to perform full range of motion result from factors such as limb positioning, duration of immobilization, and muscle, soft tissue, and bony pathology, and place the person at risk of secondary medical and functional deficits. Um, Joint overlaid by deep partial thickness or full thickness burns are at high risk of developing contractures. And this is one of the pictures that have major contraction on the elbow, hand, and fingers. Scarring, hypertrophic and to a lesser extent keloid-like scarring are common and caused by proliferation of dermal tissue following skin injury. Scar is considered immature if it is red, raised, or rigid, and mature when it's avascular, flat, pliable, and soft. Approximately 1 to 3 months post-healing, after deep partial thickness or full thickness burns. Infection, um, it is also known that early signs of infection include increased redness, warmth, pain, swelling of the wound. Early burn wound infections tend to result from gram-positive organisms such as Staphylococcus or Streptococcus. Heterotopic ossification. The incidence of HO in general burn population, including adults, is between 1 to 3%, making it rare, especially in children, but functionally important complication of burn injury. HO or heterotopic ossification results from ectopic lamellar bone formation within the soft tissue around the joint, severely reducing range of motion and compromising limb function, most commonly in the elbow, shoulder, and hip. Neuropathies, neurological impairment from the burn injury may be apparent in the time of admission or become clinically evident after 2 years post-burn injury. Patients at increased risk of progressive neurological deficits include those who have sustained an electrical injury, dysfunction, include paralysis, tremor, involuntary movement, or ataxia. Pressure ulcer or sore. Patient with burn is at risk of pressure ulcer due to physiological responses post-injury. Lymphedema. Edema is interstitial protein-rich substance that forms a gel-like consistency and impedes vascular clearance. Uh, we all know that edema is a risk factor having a burn to um, children, especially in adults. Changes in body composition. Children aged 4 years with severe burns, total body surface area less than 40%, have significant changes in lean body mass when compared with children aged 4 to 18 years. In the younger group, lean mass was lost for a minimum of 9 months post-burn injury, whereas older children were able to increase their body mass from discharge having used anabolic agents and participating in an aerobic exercise program. Therapy interventions for the child with burns. Therapy techniques following burn injury are focused on minimizing impairments to body structures as well as encouraging helpful return to activities and participation. Minimizing impairment to body structures and function includes splinting and positioning, respiratory management, and edema management. Mobility and exercise. Exercise in the acute phase of injury helps to maintain joint mobility and muscle function. When the patient is alert and able to participate, a program of active and active assisted exercise is appropriate. Resisted range of motion, isometric exercise, active strengthening, mobilization, and gait training are commenced when appropriate prior to skin healing. Hydrotherapy can be utilized when the skin has sufficiency revitalization with minimal open areas. It enhances the rehabilitation process. However, hydrotherapy is also have to be minimized due to cross infection. In the event that full range of motion is maintained, a program of stretching is normally recommended. Sustained force to tissue will produce tissue elongation and subsequent plastic change and length, resulting in improvement of range of movement. Immediately following grafting, active and passive exercise are not performed on the limb, depending on the type of graft, condition of the graft wound, and judgment of the surgeon. No exercise or range of motion is performed approximately 3 days on mesh graft and 5 days on sheet graft. Scar management, generally people considered at risk for developing hypertrophic scarring are treated for wounds taking more than 14 days. Prophylactically, to heal spontaneously of this requires graft. Scar management intervention typically include compression and silicone as well as steroid injection. Promoting helpful return to activities and participation, therapeutic relationship. It is best established when consistent therapist input is maintained across both inpatient and outpatient. Firm but gentle approach to the treatment sessions with adequate pain relief measures is uh, placed in its vital. A gentle, unhurried approach to treatment session with conversation encouragement may improve the patient tolerance to treatment techniques. Use developmentally appropriate play to facilitate rehabilitation goals. Assessment of pre-morbid functioning and ongoing education, procedural preparation for the children are also helpful. Goal setting, realistic therapeutic goals as well as appropriate plan of care should be devised by the treatment team that includes the caregivers and the child. Um, Discharge planning, appropriate functional goals prior to discharge include the ability to stand, ambulate, feed, toilet, and as well as return to school and play. Well-recognized re-entry programs to the child's community, family, neighborhood, school may facilitate the child with burn reintegration. An augmented reality device is being used to alleviate pain and anxiety during the burn dressing procedure, as you can. And that is my report today, and hope you um, learned something from my report. Thank you.